This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parts, physical therapist and your host, and today I'm sharing my conversation with Professor Jan Hartvigsen, a leading expert in musculoskeletal health and a key contributor to the World Health Organization's guideline for the non-surgical management of chronic primary low back pain, published in 2023. In this episode, we discuss the guidelines, recommendations, and the interventions it advises against, why there is a shift away from educations toward more behavioral and self-management approaches, the real-world challenges of changing how healthcare systems treat back pain, the role of clinicians in supporting self-management for patients, and much more. Dr. Hartvigsen is a chiropractor and epidemiologist and professor at the University of Southern Denmark. With over 280 peer-reviewed publications, more than 15,000 citations, and a career focused on advancing evidence-based care, Professor Hartvigsen has been instrumental in shaping global approaches to managing chronic low back pain, including his work as deputy chair of the Lancet Low Back Pain Series. If you find our conversation informative, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with your colleagues in the clinical field who could benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Neck care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi, Jan. Welcome to PT Pro Talk. How are you today?
I'm very, very good. Thank you for having me.
Awesome. So let's get started telling a little bit about yourself and your career.
Yeah, so I'm Jan Hartvigsen. I'm a professor and research leader at the University of Southern Denmark, where I lead a fairly large research center called Center for Muscle and Joint Health, where we are around 50 researchers that do quite broad-based research program in musculoskeletal health. My clinical background is as a chiropractor from the late 80s, actually, and I practiced as a chiropractor for 12 years. And during the last 4 years, I became a PhD student. And when I got my PhD in 2001, I stopped seeing patients, and I've been a full-time researcher and academic for the past 25 years. So that's, in a nutshell, what I do and my career.
Long journey. That's awesome. You got the academic background and the clinician background at first. So
yeah, absolutely. And during that time, I've managed to have 2 children who are now living their own lives away from home. So it's been a busy 35 years.
Yes, that's great. So let's dive into our conversation here and talk about the guidelines. So could you give us an overview of the World Health Organization guidelines for managing low back pain? And I know you play a role on helping writing them, right? So could you just tell us a little bit about that?
Yeah, so the reason why the WHO became interested in writing and publishing a set of guidelines for management of chronic low back pain was because the global burden of disease studies showed repeatedly that low back pain is the number one reason for disability in the world. Projections show that this disability burden is going to increase over the next 2 to 3 decades, in particular in low and middle income countries. And that's because there is a population growth and because people are getting older mostly. And of course, all musculoskeletal health problems are important from a disability perspective, but low back pain is the biggest one. And that's why they decided to focus on low back pain first. So I was contacted originally by the WHO, and they asked me to help them write a proposal or a background paper to suggest to them and to their boards that they indeed formulate guidelines for management of low back pain. And so I did that, spent a couple of months doing that. And later on, I became involved in the guideline development group. That was a group of 25 experts from all over the world. I lived in Denmark. I was the only one from Denmark. We were 3 from Europe, and then people from globally, Africa, Asia, India, South America, North America, Australia, who met online, mainly during COVID, over a couple of years. Together we worked on this guideline. It was published in December of 2023.
And so how did you develop that? So how did you get to those recommendations?
Yeah, it was a long journey. First, we had a list of interventions where people could suggest interventions that are used to manage low back pain. And I should say here that this is about managing low back pain in primary care and community settings. So we're not talking about surgery and specialized pain centers and university hospitals. We are talking about managing low back pain in the community, where most people with low back pain are and where most people with low back pain seek care. And as you can imagine, if you gather ideas from all over the world, there are a lot of different interventions that are used, and some of them, in fact, many I'd never heard of. I didn't even know what it was. So the first thing we did in the group was to agree on a set of interventions that we would like to evaluate, and I believe that we agreed on 37 interventions. Physical interventions, psychological interventions, and pharmacological interventions. Then we decided that we needed to have updated systematic reviews or evidence syntheses for all of these interventions. So we had a scientific foundation, if you will, at least concerning the evidence and the harms of these interventions that could inform our decision making. So those systematic reviews were commissioned by different research groups around the world, and people in the guideline development groups were not part of the writing, the evidence synthesis, and the systematic reviews. That was done independently of the WHO and independently of the guideline development group. And then when that was done, we had kind of the scientific foundation that could inform our evidence synthesis. And then we considered for all interventions, not only benefits and harms, but also how they would impact equity and access to healthcare, and how they would be feasible on a large scale, if you looked at it from a global perspective. And also, we didn't do cost effectiveness analysis per se, but we also had informed opinions about the cost of these interventions that also played into, what can you say, deciding on the different recommendations for or against. So it's a very lengthy process, and it involved very many people. And it was also, as you can imagine, a fairly expensive exercise, but it was very thorough. And I felt really good afterwards that it had been such a thorough piece of work. And I think we can have at least some confidence in these recommendations that they are a good way and an evidence-based way of looking at management of back pain in primary care and in community settings.
And that was all based on systematic reviews, right?
Yeah, so they were all based on systematic reviews of these interventions, this long list of interventions, compared to either no treatment, sham or placebo treatments, or usual care. So we looked at whether these interventions, it looked like they provided benefits for patients that was beyond the natural course of their condition. And that is, I think, the very basic level of evidence you would expect for any intervention, that it's better to have the intervention than to not have anything. we did not look at one intervention compared to another intervention. So, for example, we did not look at spinal manipulation compared to exercise. We did not look at that. We looked at spinal manipulation compared to no treatment, placebo, usual care. Exercise compared to no treatment, placebo, usual care. And looked at whether they were beneficial compared to those comparators, but not how they compare to each other. So we did not rank the interventions to say that one is better than the other when they're compared. That we did not do that. That would have been a much larger job to do that. Yeah, if it indeed had been possible, which I very much doubt actually.
It was mainly like recommending if that was helpful, or if produced good results or good outcomes, or if it's recommended.
Yes.
Right?
Yes.
Yeah. Okay. And you separate that into treatment classes, right?
Yeah.
So how was that structured? You had like 5 different treatment classes.
But actually, first we when we had started the work, we started to talk about, because people brought perspectives from many different cultures and countries. So we started to say, we probably need to formulate some basic principles for care for people with back pain. And we formulated 4 principles. One was that people should be, so I'll see if I can remember them off the top of my head, but that people should receive information and education about their condition so they understand why they have pain, what they can expect from their pain, and what they can do themselves to help themselves. That communication with patients should be non-stigmatizing, it should be non-prejudiced communication, that there should be equal access to recommended and effective care, that it should be independent of status and finances, and finally, that care should be coordinated between all the different providers and many times social instances that are involved when managing or helping a person who has chronic back pain. So that care should be coordinated across sectors, and all information should be available to those involved in helping helping that person. So some basic principles for care that I think actually, looking back, are just as important and maybe even more important than the specific recommendations for treatments and interventions. Those principles for care, especially about helping people understand about their pain, why they have pain, what they can do themselves, and also equal access to good care.
Yeah. Education is so important, because if they understand, that changes everything. They bring them on board, and they know their role in the process.
It takes away a lot of the uncertainty, and it gives and helping people to gain confidence in their body, and that they can actually live a good life despite of some pain occasionally.
And that was the first intervention class, right? Education.
Yeah. So that was the first intervention class, and I think one important, besides from what I've already said about education, is that the patient education part is different from the normal conversation you will have with a patient during a clinical encounter. We clearly wrote that. So it's a conscious, structured information or session where you help the patient make sense of their pain and gain a deeper understanding of why they have pain and what they can do themselves. It doesn't invalidate the normal conversation you have with the patient, but it's just to say it's different from the normal day-to-day interaction you have with your patient while you are treating them, for example.
Mm-hmm. Okay, so now I have to ask, so how is it different? The structure of the conversation is different? Like, what do you think that's the main difference between that structure and the day-to-day conversation that clinicians have?
It's because you have a conscious list of issues that you want to discuss with the patient. And it's not all patient. It's not in all instances that you have to discuss every issue with the patient. That would be way too much. But that you have a list of items or domains that you know you want to cover with that patient. That could, for example, be the natural course of back pain. That for most people who have chronic back pain, you're not going to cure them. They are, in fact, after your treatment, also going to have some level of pain. They will experience flare-ups. That's normal. Don't be alarmed by that. What can you do when your pain flares up? What do imaging findings actually mean? So you make sure you cover these domains with the patient in a structured way and that they understand it. Yeah. But the point of departure is the individual patient and what they think. So for some patients, some domains or some issues are really important. They're very concerned about that. But for other patients, it's other issues. But it's just to help the clinician have a structured framework around this that they can refer to make sure that they cover these important domains. And we talk about that in the guideline and also in some papers.
Mm-hmm. So that's really good. So then the clinicians don't forget the important points that they should be talking to their patients.
Yeah, exactly.
Regarding that. Okay. And how about the second intervention class? So that's the physical interventions.
Yeah, you have to help me here if I forget some of them. But of course, we
I have a few notes. Let's see.
we recommend 4 structured exercise programs. An important part of them, sorry to go back to the education part, but it is so important, is to talk to people about remaining active, remaining physically active, remaining socially active, and remaining at work, if that's at all possible. But we also recommend moving to the next class group of interventions, the physical interventions, the structured exercise programs. We know that can be beneficial for many patients. It can help them better cope with their back pain. It also helps the pain and disability. It's not a miracle cure for back pain, but it is beneficial without a shadow of a doubt, and it helps patients. So we recommend that. We recommend a manual treatment like spinal manipulation and mobilization. That can also be helpful for some patients. We recommend needle therapies like acupuncture and dry needling. And finally, I think in that class, can you help me? Massage also, yes. Yeah, we recommend that, yeah. And some of these interventions do not have strong evidence for effectiveness, but they do have good evidence for safety and also that they are available and that they are inexpensive in many countries. And that also weighs into the recommendation that they are widely available, inexpensive and safe. And there's some evidence for effectiveness also.
Mm-hmm. And on the structured exercise therapies,
Mm-hmm.
so do you have any specific recommendations on that? What would that mean, structured exercise therapies?
Yeah, that's a very good question too, because as you probably know, when you look at the evidence, there's not good evidence that any particular exercise or exercise regime is more effective than another way to exercise. So I think what we mean by that is an exercise program where you again use the individual patient as the point of departure and say, well, you need to have something that strengthens your back, that strengthens your front, that strengthens your buttocks, your pelvis, your legs. You need to have some flexibility. You need to have some balance. You need to have some core stabilization exercises. It's a well-rounded exercise program. And exactly how you approach that depends on, I think, the situation, the clinical picture in the individual patient, and also their preferences and also clinician preferences. There's a lot of room for preferences here. And I think the most important the most important advice about exercise is about helping patients gain confidence in their body, that they have a strong body that can actually do many things, and help them explore movement and give them the joy of moving and using their body and not being afraid of it. Those are some of the ingredients in a good structured exercise programs. But delivering good structured exercise programs is really a highly advanced clinical skill. it's not something that's just mechanical, just do this. It's really looking at the patients. What do they need? How can I help them move, get stronger, gain confidence in their body? And that's what we mean with a structured exercise program.
Okay. And now how about the spinal manipulation? I know that's a little controversial nowadays, so there are, people talking good about it or not so good about it. So like what did you see in all your research?
Well, we saw that there was a small benefit when it was compared to no treatment and sham treatments. We know it's a safe treatment. We know that it's widely available. We know that many patients find it helpful. So we recommend it as an option for treatment as part of interventions. I think we also write that it should not be a standalone intervention, but it can be part of a package of interventions. And I think that spinal manipulation, mobilization can be very good and helpful treatments. I think many clinicians and patients will say that, and it would be stupid to disregard that. Again, it's not a miracle cure for back pain, but it's a strong clinical experience, and there's also research evidence that it can be helpful for patients. It doesn't help everybody, but in the right combination with these other treatments, it can be a helpful intervention. I think that's how you should see it.
Okay. And I know like massage and needling, if you think about that as well, it's like also passive. So I assume you would not recommend as a standalone.
No, absolutely. Absolutely not.
That's the same idea there.
Yeah, exactly. Yeah, exactly. Yeah. And I think it'd be very difficult. I mean, considering how common acupuncture is, in particular in Asia, it would be very difficult to recommend against it, if you will. And there's also some evidence that it can be helpful, but again, not as a standalone treatment. But if there's a patient preference combined with education, combined with keeping active and exercise, by all means, go ahead and use it.
Because you're going to talk also about self-management. So now thinking about all these physical interventions, self-management, then the exercise will probably be the one that fits better because the patients can do themselves, right? So that's something really important that you have to consider when you're thinking about these physical interventions.
Absolutely. Yeah, I completely agree.
Okay, we're going to discuss that.
Yeah, we're going to come back to that, yeah.
Yes. So let's hold the thought. Then we go to other things that was a recommendation against use, right? Do you want to talk about those?
Recommending against?
Against, yes.
Maybe we should talk about, yes, there are a long list of things, and I don't remember all of them that we recommend against. But I think what's most important in this guideline is that we recommend against the use of most medicines or most pharmacological treatment. And I think that is the most important message from this guideline. It's a move away from pharmacological treatment towards education, exercise, and physical treatments for back pain. And that's because, one, there's now good evidence that most pharmacological treatments are not helpful. And pharmacological treatments are really good to study from a scientific point of view because you can have two identical pills that look identical, but one has the active ingredient and one does not. One is a placebo pill. And then you can randomize people and you can give them these pills and you can see whether the group gets the pill with the active ingredient have better outcomes than the placebo group. That's very difficult with an exercise intervention, for example. And very good placebo-controlled randomized trials have shown that for paracetamol, for opioids, and to some degree for NSAIDs, but mainly for paracetamol and opioids, there's no benefit in taking these interventions. And we know that they have or can have very serious side effects. So when you weigh the benefit versus the harm, it led us to recommend against the use of these medicines. The only commonly used medication we ended up recommending for was NSAIDs, non-steroidal anti-inflammatory drugs. and only after careful considerations for a short period of time, and only in people under 60. So I think the message here is there's quite a limited role for pharmacological treatment in managing chronic back pain. And that, in my opinion, is a paradigm shift from previous guidelines, and at least from a couple of decades ago.
Okay, and even muscle relaxants, right? Relaxants and local anesthetics, injectable local anesthetics, all of that, which I think at some point the muscle relaxants was very common.
Yeah, well, they've all been very common. I mean, we've given all kinds of drugs to people with back pain. And when you look at the trials, there's just no evidence for effectiveness or evidence that the benefit is very, very small. And when you weigh that against the potential harms, we end up saying, well, we cannot recommend this for routine use. It doesn't mean that you can never use it. It just means it shouldn't be used routinely.
Mm-hmm. And what do you think that prompted this change?
Well, I think that we now have better studies. We have more evidence. Yeah, it's simply we have more and better research.
Mm-hmm. Yeah. Okay, and now recommendations against use that I wanted to discuss. Traction on the physical intervention is to traction, therapeutic ultrasound, and transcutaneous electrical nerve stimulation.
Yeah. Well, in my country, those are interventions we have not used in 20 years, so it was not a surprise to me. But maybe in some parts of the world, it was a surprise. But again, it's simply looking at the evidence for effectiveness, and we couldn't find it. It didn't come out in systematic reviews as being effective for anything.
I think it's kind of crazy because in the US, I practiced in the US for a while, we build in a certain way that stimulates clinicians to build like electrical stimulation, ultrasounds, modalities in general. So that is, and traction and all of that. So it is sad.
Well, that's probably what this guideline has resulted in many countries, is that administrators, politicians look at it and say, wow, we really need to change our back pain care pathways and how we design the system in an evidence-based way. And it is indeed going to be a challenge everywhere.
The reimbursement should be different, so then people are not.
Yeah, it doesn't make sense that you reimburse people to do things that are ineffective or many times even harmful to patients. We need to change reimbursement. We need to change health systems so they support evidence-based care. Because you can't blame clinicians.
I received like orders. You have to build modalities because we need X number of units. And then what do?
Yeah, exactly. So you should reward clinicians for doing good patient education, for helping people to live better lives and to better self-manage their pain. And you should take the money from electric modalities and pharmacological treatments and those kind of things and shift reimbursement to get better care.
And use that time to do good education that we know
absolutely
we should have more focus on.
Yeah.
And how about the lumbar braces, belt support?
Yeah, again, in my country, my part of the world, we haven't used those for decades. I remember back in the 90s, we still used them, but not anymore. I think that, again, it's not that you can never use a lumbar belt if you have very heavy physical work, if you move pianos or something. I wouldn't say that you can never use it, but it should not be used routinely, and there's no evidence that it is an effective intervention on average, but of course you can rule out that few people find it helpful, so reserve it for the few people where you think it might be helpful, but not use it routinely.
Yeah, okay. How about mobility assistive products? So that was a good practice statement?
Yeah, so there was really no evidence, no clinical trials about this, but what we said is that if people need a walker or a cane or a stick, by all means, let them have it. Even though we don't have any evidence, a good practice statement means that there's no evidence, but we agree in the group that for some people that can be a good idea if they have a high level of disability. For example, older people, we had a special focus on older people because we have an aging population all over the world. And especially for older people, these mobility assistive devices or products can be very helpful in maintaining mobility, especially outdoors. So we should be conscious of and helping people to get those devices if we think that's helpful. Not based on evidence, but just based on common sense.
Yeah. And another intervention class was psychological interventions, right? So you had some recommendation in favor, cognitive therapy. Do you want to just talk a little bit about that?
Yeah, we evaluate evidence for cognitive behavioral therapy and different variations of that. I mean, there are many. It's just like types of exercise or types of manipulation. There are many different schools of thought, but generally it looks like that can be helpful, especially for people who have dominating psychological issues with their pain. And after the guideline was published, we had the Restore trial that came out. You might have heard about that, where we looked at cognitive functional therapy. I played a small role in publishing that paper, where we indeed showed quite a large effect size for cognitive functional therapy. That was indeed patient education, an exercise program that helped patients make sense of their pain and challenging them, and general lifestyle advice, and produce quite a large effect size. So I would group that in those psychological therapies. They can be helpful, absolutely, and that's why we recommend them.
I was just curious, what is operant therapy?
Yeah, so I'm not an expert at all. It's I might get into trouble for saying this, but it's a type of cognitive behavioral therapy where they have a particular approach to the patient. That's as far as I would go into this, but it's a psychological intervention. Yeah.
Okay. Any other observations? Anything that was a recommendation against use? I don't think so, right? On the psychological, that was just no recommendation. Mindfulness, based stress reduction therapy, it was like no recommendation, low certainty evidence.
There was so little evidence, so much uncertainty, we couldn't really make a recommendation.
Cognitive therapy, the same thing, right?
Yeah. There were a number of interventions, not too many though, where we could not make a recommendation. There was no evidence, and we looked at it and we discussed it and decided that we would rather not make a recommendation based on the current evidence. Yeah.
Any comments on herbal medicines?
Yeah, so we looked at herbal medicines too, and found that there was very little evidence, but we do recommend for one topical cream with cayenne pepper in it. I would consider that an herbal medicine because there were a couple of small trials that showed that in the meta-analysis that it could be beneficial, and we could not think of maybe apart from, I don't know, that it wasn't too pleasant to have it on your skin. We really couldn't think of any other recommendation that could be considered use. Yeah, but we need much more research, effectiveness research, good clinical trials in herbal medicine, and I really recommend that we do that, because I think there might be a potential there.
And you had two that were against use. So white willow, is that how you say it? And devil's claw?
Yeah, they're used not uncommonly around the world, also in Europe. But
I never heard about them before.
No, but that speaks to the different traditions around. Yeah. And we couldn't find evidence that they were helpful.
Okay. And now moving on to the last intervention class, multi-component interventions.
Yeah. So that would be interventions where you, for example, refer to a specialized pain center where they do multi-component interventions if you have high levels of disability, secondary care, tertiary care spine centers where you have both pain psychologists, physiotherapists, rheumatologists, and you come at the patient from different perspectives and you do a multi-component intervention. And there's some evidence that that can be helpful to patients too.
The biopsychosocial care, right?
Completely. Yeah, I think we need biopsychosocial care right from the beginning. But if you get it at the very end stage when you have high levels of disability, it can also be helpful.
And then it was against use the weight management, the pharmacological weight loss. That's now a big thing, at least I guess in the US it is.
It's a big thing everywhere. Yeah. Well, there's just there's no evidence that, I mean, there's an association, if you will, between obesity and back pain. If you have high degree of obesity, and I guess many people in the US are quite obese, but there are not good trials that show that if you lose a lot of weight, your back pain will get better. And there are no trials showing that if you use Ozempic or some of the other drugs to lose weight, that it will help your back pain. There's now a good trial showing that it can be helpful for people with knee osteoarthritis. So maybe it can help people with back pain too. We just don't know. So we couldn't recommend it based on the current evidence, but who knows in the future?
Yeah. So, and what do you think that prompted that shift also from like the biomedical to the more behavior perspective? Do you think it's the same thing, the studies that are being published?
I think simply now we have more studies, we have better evidence. And the way it has turned out is that these more behavioral approaches, physical approaches, seem to be more helpful than the biomedical approaches. And I think also importantly, they are a lot safer. Because the pharmacological treatments, other types of treatments and biomedical treatments often come with at least the risk of serious side effects.
Yeah. And we talked about this a little bit, challenges on implementing this at the healthcare system. So what do you think are the key challenges?
Well, the key challenge is that probably the most prevalent common form of treatment is pharmacological treatment. So if you look at this guideline and say, well, we shouldn't use much of the pharmacological treatment routinely, it will require health systems and reimbursement systems to change. And I think that is that's difficult. It's going to take a long time. And I think that there are strong vested interests that will work against that because there are people who really benefit from the system as it is. And they're not going to be very happy if we shift reimbursement and shift strategy in health systems. So I think it's not only about research and evidence, it's also about political action and changing health systems. That will take a long time, but I have no doubt that this is the direction that back pain care, and indeed I think most care for musculoskeletal conditions, will take away from the more biomedical view towards a more behavioral view and treatments that help patients live good lives with the body they have, and despite having pain from time to time. And research has shown that that is indeed possible. So it's now up to administrators, clinicians, politicians to get together and think about how can we do this. And it's a super tanker. You need to change direction. It takes a long time.
And I think also like educating doctors is a big piece, because if you're talking about pharmacological, if the doctors are not educated on like the importance, like on these guidelines and the importance of education and movement, they're going to continue just prescribing medication and very often not even prescribing exercise.
Exactly. I think an obvious place to start is with students, at least to make sure that the curriculum that students are taught in universities and different schools or wherever they study is evidence-based. So at least the new clinicians come out with contemporary understanding of musculoskeletal health management. And then there is a big job with postgraduate education for doctors, but also for other healthcare professions, allied healthcare professions, certainly.
Yeah. In your experience, have you seen this being implemented in some healthcare systems around the world, or not quite there yet?
Yeah, well, I'm seeing that in many places there's a big interest in implementing this. And I think there are many good initiatives that I'm aware of, and what can you say, studies, model projects where they say, well, what happens if we shift reimbursement, if we do this and that? So I don't think we are there where we can say that health systems have changed because of this. But I do think that a year and a half is also a very short time.
Yeah. It takes a while to.
It takes a while.
Yeah.
Exactly. But this resonates well with decision makers and administrators, certainly, because they see that now that there's evidence that a more behavioral, demedicalizing approach is helpful. And there's also good evidence now that it can be cost effective, which always gets the attention of administrators. If something's better and cheaper, those are two very good arguments to administrators. Then it takes time, but I'm quite optimistic with this, but it will take time and longer than any of us want it to take at the end of the day.
And if it's cheaper and takes, less time, we are talking about self-management. So education, empowering the patient, exercise, all of that, when being implemented, it's meant to help the healthcare system, right? So you shouldn't have that much resistance in.
No, well, first and foremost, it's there to help the patient, and we know it's to help, but it's a win-win situation because it also helps the health system. So we know that it's a good model for patients, and it's also good for health systems if we can find a way to implement. But I think it's important to say that self-management is not about just leaving the patient alone and say, oh, self-management, oh, figure it out by yourself. That's not what it's about. I'd rather maybe use the term supported self-management, where the clinician helps the patient through education, through exercise, for example, to get more confidence in their own body and know why they have pain, but also knowing when to seek help in the healthcare system. And then the healthcare system should be there for them, and knowing what type of care to seek. So now, if you go to see a doctor or to an emergency room in many countries, you will almost automatically get opioids or strong pharmacological treatment. And patients knowing that that's not a good treatment, it's not a good treatment option, and have them seek out other types of care. That's part of self-management too, finding your way and knowing the health system, what types of treatment to seek out. But most importantly, it's clinicians supporting patients in living better lives and taking better care of their own body. It's not unlike, for example, at least in my country, if you are diagnosed with diabetes, you can get medication, and many people do. But you also learn about nutrition and exercise and how you can live a good life with diabetes and things you should watch out for and things you can do. And patients gain confidence and say, well, shit, I have this diagnosis of diabetes. But hey, there are many things I can do, so maybe it's not so bad after all. It's looking at those models from other chronic diseases and say, what does that look like in back pain?
Mm-hmm. And like in your opinion, what would be the perfect model when you see like the clinician supporting the self-management for patients? So if you could, think about the perfect world, how would that look like? Would like the patients go and check in like every now and then, they get educated, and they go back when they need and check in again and get some advice, and how would that look like?
That's a big question. I'm not sure I can answer that. But I do know that what it does not look like.
Okay.
So it does not look like patients going to a doctor, getting referred for imaging right away, getting strong pain medication. That's not what good care looks like. So we should stop doing that. Patients should be met with evidence-based information. They should be met with compassion and education or conversation that can remove their anxiety and fear for their condition. And they should be equipped with tools or that they can use in their everyday to manage their pain. And then there are those who need to go into, for example, structured exercise programs and say, well, you need to come back a number of times and we talk about this and you do these exercises, we build your strength and we build your confidence in your body. And we can also, there's some evidence that manual therapy can maybe be helpful. Would you like to try that? Maybe that can help you too. But the most important part is the exercise and the patient education part. And these are the types of conversations we should be having with patients. And that clinicians should be reimbursed for that rather than prescribing strong pain medications and just giving referral for imaging that are, for most patients, not helpful at all.
Yeah, absolutely. And any resource of information that you recommend, like if people want to learn more about the topic? I know you have the series of low back pain on the Lancet, right? I don't know if that influences the guidelines at all, if there is any connection there, or if people, I know they can Google these guidelines and you can find all this information. So what would you recommend people to go check?
I think the Lancet series was incredibly important for the guideline, also because we had a call to action in the Lancet series, and one of the calls to action was for WHO to make a guideline.
I saw that. I was like, that's probably related. I was going to ask you.
They got back to me. I was one of in the steering group, and they got back to me and said, "Can you write the application?" So there was definitely a connection.
Okay, great.
But then I think that, and I think the guideline report that's available online, free. There's a lot of fantastic information in the text. It is an Australian professor, Andrew Breaks, who wrote the guideline, and he's a phenomenal writer, and he wrote very good text. There's also a paper that we wrote about self-management that was published in the Brazilian Journal of Physical Therapy, actually, called, I forget what it was called, but it was about supported self-management and what it looks like in primary care. So how to plan it, how to do it, how to evaluate it, just 10 tips for clinicians, those kind of very down-to-earth pieces of advice that you can look up. I was the last author on that paper, and my good colleague Alice Kongstedt was first author. You can look up that paper. And that has links to many good online resources that are, many of them are free, that you can access videos, different types of material that you can access and use. I think there's a lot of good material out there.
Very good. So your call to action worked.
Some of it, we also called for reimbursement to shift. We still have to see that.
At least one of them worked.
One of them worked, yes, exactly. Yeah.
And any advice to clinicians that are starting their careers?
Yes. I think this is a very, very exciting time to be a back pain and MSK clinician because there's so much new information coming out, which is exciting. I remember 30, 35 years ago, it was all more or less the same. Now we are learning new things all the time because of new research coming out. So follow the research. Be aware of evidence-based guidelines. Seek out the people who are involved. Listen to podcasts like your own. There's so much good information out there. Be curious. Question what you are taught in university and in school, because more likely than not, it's already outdated when you graduate, and you need to. Of course, you get good educations. I'm not saying that, but there's so much new information coming. Be curious. Go to courses with people who are at the forefront of clinical evidence in back pain care and MSK care, because there's so much new stuff to learn, and that's going to continue for a long time. So for new clinicians, I'd say you have chosen an exciting field, and tomorrow will look different from today.
Yeah, and you graduate, and then there is a whole new road of information that you have to dig in and start paying attention. It's just the very beginning.
Exactly.
Yeah. And before we wrap up, anything else that you wanted to mention? Anything we forgot? Any final thoughts?
Oh, I can't think of it right now. I think we covered a lot of ground.
Yeah, we did. Awesome. If people want to find more information about you or your research, how they can find that information?
Yeah, so I'm in quite a few podcasts you can Google. You're also very welcome to write to me. Absolutely. Google our Center for Muscle and Joint Health. There's information there. So yeah, that's about the best. I used to be quite active on Twitter, now X, but I got so fed up with it. I'm not active there anymore because since a certain American billionaire took over, I think it has all changed and I'm not part of it anymore. But now I post stuff on LinkedIn and maybe, so I'm a little bit visible on social media too, but not a whole lot. Not as much as I'd like to because it takes time.
Yes, it does take a lot of time. Well, that's great. Jan, thank you so much for taking the time and sharing a little bit with us today about the guidelines. It's very helpful. I'm super honored and happy to have you here, so thank you so much.
Of course, thank you so much for having me.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.